All right. Looks like we have about 130 participants so far, so I think I'll go ahead and get started. So good afternoon. Thank you for joining today's webinar. My name is Beth Flatham. I'm one of the Vice Chairs of Administration for Mayo Clinic Health System Southeast Minnesota region. Today, we'll learn from two incredible women how preventive care keeps you feeling your best. Dr. Jennifer Horn will discuss the top health risks for women in the current environment and the importance of prevention and screening. Dr. Helena Gazelka will share her personal healthcare journey and her inspirational message of things my mother never told me. So we invite you to use the Q&A feature to post questions anytime throughout the event. And as a note, this webinar will be recorded. So without further ado, let me introduce Dr. Jennifer Horn. Dr. Horn is the Chair of Clinical Practice for Mayo Clinic Health System Southeast Minnesota region. She is an assistant professor of family medicine at the Mayo Clinic College of Medicine and completed her medical degree and residency in family medicine at Mayo Clinic College of Medicine in Rochester. Dr. Horn joined Mayo as a consultant in 1995. So prior to her current role, she served as chair of the Rochester Division of Family Medicine. Her clinical interests include primary care healthcare delivery and how physician factors relate to quality and value in primary care. And when Dr. Horn isn't at work, she enjoys Nordic skiing, cycling, knitting, gardening, and nature. So I welcome the opportunity now to turn the presentation over to Dr. Horn.
Thanks so much, Beth. And I'd like to start by just giving a welcome and a thank you to you all. Thank you to you all for taking this hour to learn about how to care for yourself. We can't care for other people if we aren't caring for ourselves. So good for you for doing this. I'm going to take a minute here and share my screen with the presentation. And is that looking right to everyone?
Yes.
All right, thank you. So we have three goals today, as Beth shared. I would like to talk about some of the biggest threats to women in today's world in terms of our health, talk about what we can do to avoid some of these threats or delay them or sometimes even prevent them altogether. And then we'll take a little bit of a deeper dive into what preventive screenings are recommended for women. And I want this to be an interactive session, so please feel free to use the Q&A to post your questions. I already have some great questions in there that I'm looking forward to answering. And you can ask as detailed as you want. If I don't know the answer, I'll simply have to get back to you, but I'll find it. So according to the U.S. Preventive Service Task Force, the leading causes of death in women in the United States are listed here. And those include heart disease, cancers of all types, chronic lower respiratory disease, which would include things like asthma, emphysema, chronic bronchitis, strokes, which is another form of vascular disease related to some of the same causes for heart disease, Alzheimer's disease, which was news to me. That was a nice learning for me in creating this talk. And then unintentional injuries, things like falls, car accidents, bicycle accidents. So what can we do as women to help prevent some of these things or many of these things? Well, it's as easy as 1, 2, 3. It's also as hard as 1, 2, 3. We can manage our chronic conditions if we have them. We can get our screenings done, and we can understand and know what screenings are pertinent for us as an individual woman. And we can adopt a healthy lifestyle. So we're going to go in depth into each of these categories. I want to take a minute to talk about some of the barriers to achieving improvements in those three categories. Increasingly in Western medicine, we're recognizing the importance of the environment in the health and wellness of individuals. Our colleagues in public health and social work and many other helping sciences have known this for decades, maybe long centuries probably. But we're just getting on top of this. And you may have heard of the social determinants of health. I'm going to give you the definition of the social determinants of health, which comes from the Healthy People 2030 plan, which I would encourage you to check out. It comes from our Department of Health and Human Services. The social determinants of health are conditions in the environment where people are born, live, learn, work, play, worship, and age that affect our health functioning and our quality of life outcomes and risks. At our clinic here at Mayo, in all of our clinics, we now ask questions pertinent to the social determinants of health every time we see people. And sometimes this can feel annoying because we ask the same questions again and again. For instance, tobacco use. We're going to ask you that hundreds of times over the course of your relationship with us, but it's because we believe it is so important for us to know and understand that and how we can help be a partner with you in improving your health by potentially getting ready to and quitting smoking. The reason that I, as a family doctor, think this is so important is because if let's say I'm seeing a woman in my clinic and she wants to lose weight, she has obesity as a problem, as a chronic medical disease. If I don't know that she's homeless and living in her car with her 2 children, I'm not really going to be able to help her or understand how to help her. And so it's just critical for me to really understand you as a patient and where you're at so that I can give suggestions or make connections or referrals that actually make sense to where you are right now in your world. So managing chronic conditions. What do we do to manage our chronic conditions? I want to share that heart and vascular diseases are the leading cause of death for women in the United States. And you may or may not know that things like stress, diabetes, high blood pressure, and smoking all contribute to heart and vascular diseases. So by managing these things, we can prevent heart and vascular diseases. And that's why your provider is going to be pretty aggressive if they find out that you do have high blood pressure or that you do have out of control diabetes. They're going to really want to help you control those things so that you don't go on to develop a life-threatening heart attack. So managing stress, and we're going to talk a little bit more about that because that's a difficult thing to do in today's world. Controlling our blood pressure, either through lifestyle modification or medications. Controlling our diabetes, again, either through lifestyle or medications, often a combination of all the above. Quitting smoking, getting ready to quit smoking, or even just thinking about quitting smoking is a super important step. Being as active as we are able to be. What we put in our bodies directly affects our health. I seriously believe that food is medicine and that there are things that we can do, like shopping from the exterior of the grocery store, that are going to help us be healthier people. We also recommend that women limit alcohol to 1 drink per day. And this is based on evidence of how alcohol affects women, their function, and their long-term health. Moving into screenings, it's not a one-size-fits-all game. Some women, because of their risk, are going to need different screenings. And when we talk about screenings, we might be talking about a simple set of questions. So the social determinants of health questions are a screening questionnaire. But there are also screening tests that we do, or screening procedures that we do, like measuring your blood pressure. And I'll try to be explicit about those as we go through the talk. Some women have increased risk just based on their genetics alone. And so if you have questions about this, please speak up and ask. The most common cancer screenings that come up and that we recommend for all women are breast cancer screening, and mammography is our standard tool for that. But there's a whole arsenal of additional testing that we can do for women who have increased risk. Cervical cancer screening, which now should include cytology and HPV testing, and then colorectal cancer screening. And the main tests we use for that are colonoscopy, Cologuard, which is a stool test, and fecal blood testing. And I'm happy to talk about intervals for those if people have questions, but I also have references in the appendix that you can link to and see them for yourselves. We do a number of mental health screenings. We should be doing these once a year or more often for people that are at risk. And these include alcohol use, depression, and intimate partner violence. We use screening tools that have been standardized and validated. The one for depression is called a PHQ-9. Probably, I hope most of you have had that at some point in your interactions with healthcare. For anxiety, which we're seeing a lot of right now during the pandemic, we use a GAD-7. So these standard screening tools are really valuable for us in understanding where you as a patient are at right now. And as we do interventions, it helps us understand if the intervention is working. There's a number of screenings and testings we do for risk for chronic disease development or for control of chronic disease. So for diabetes, we would do a fasting blood sugar to screen for that. And we do a test called an A1C also to screen, but in addition to show if you do have diabetes, how well are you controlled? We screen for hyperlipidemia with cholesterol profiles, for hypertension with a blood pressure check. There are lung cancer screenings now available. We do a questionnaire to see if you fall into a high-risk category. And then if you do, we would offer you a CT scan, which is a fancy X-ray test that can be very sensitive for detecting early and treatable lung cancers. We screen for obesity by measuring your height and weight, because obesity does lead to literally all of these other chronic conditions if not controlled. We screen for bone health using questionnaires to assess your risk. And then starting at age 65, we recommend bone density screening. We do it much earlier for people who are at risk or have other indications. And then, as I said before, we screen for tobacco use virtually every time you see us, because if we can successfully make an intervention here, we can prevent all of these other chronic conditions. Infectious screenings include hepatitis B. We screen everyone for risk with questionnaires. Hepatitis C, USPSTF, the US Preventive Service Task Force, recommends we screen everybody once with a blood test between the ages of 18 through 79. And then for HIV, it is now also recommended that everyone gets screened once in their lifetime or based on risk. For sexually transmitted infections, we recommend screening for all sexually active women yearly, depending on their risk. It doesn't matter what age. Let's talk a bit about prevention. Preventive immunizations that we recommend include this list. I personally believe that all of these immunizations are extremely safe and extremely effective, and I recommend them to literally all of my patients. Of course, we do shared decision-making. Every patient gets to decide what's best for them, and we talk about any risks or reactions that they may have had in the past. Moving on to adopt a healthy lifestyle. I get really excited about these things as a family doctor because I know that they have cumulative effects. If we eat healthy, if we're at a healthy weight, and if we keep ourselves active, it's going to not only help our physical health, it helps our mental health, it often helps our relationships. Choosing vegetables and fruits as the base of our food pyramid is really important. Shopping from the exterior of the grocery store, like I said earlier, and limiting fats and sugars is the key. People can literally transform their lives by going to a more plant-based or Mediterranean diet. There's science here. I've seen it happen for many, many patients. Maintaining a healthy weight is very challenging if we already struggle with weight, but your healthcare team and your community resources are there to help you when you're ready to make a change in that. And as I said before, keeping moving, so important for mental health. Also, it's preventative for heart disease, stroke, some cancers. The key here is to choose things that you really enjoy doing, because then you're going to keep doing them. And that's why I Nordic ski, because I absolutely love it. It just makes me so happy. It fills me with joy. My endorphins are going, and it's also good for me. Adopt a healthy lifestyle. I've hit on these things all already, but I'm going to mention them again. Smoking, if that's something that is part of your life, if you can make that change, it's going to have the biggest impact on your health of anything else you could do. Limiting our alcohol consumption, managing our stress as best we can. What does that mean? How does that look? Well, it's different for everybody. I mean, for me, as I spoke, it's about exercising, being out in nature. I do a lot of breathing exercises. I enjoy yoga. Therapy is a wonderful gift to give yourself. It can be incredibly helpful if you feel overwhelmed or if you feel like your resilience is at a place where it's critical. And then finally, this is so simple, but yet it's so hard to do for many multitasking women, is to get our sleep. I mean, we really truly do need 7 to 9 hours of sleep a night. And if we're not getting restful sleep, it will definitely contribute to chronic conditions like heart disease, obesity, and other things. There's science there. Other things to consider. What if I can't afford these recommendations? What if I can't quit, lose, move, or manage? What if I do all these things right and I still feel like something's wrong? Or what if I don't agree with the recommendations or I'm scared about the recommendations? Well, this is why your healthcare team is here. It's why community resources are there for you. It's what your friends and neighbors are for. Talk about it, ask questions, attend things like you are today. I'm preaching to the choir here today. But reach out, ask the question, have the dialogue. Let's do some shared decision making around these things. And as I said, your healthcare team is there to help you connect with resources that could help eliminate some of these barriers. So with that, I thank you for your attention and again for tuning in, and I am looking forward to the questions. And Beth, are you going to be moderating the questions?
I will. Thank you so much, Dr. Horn. I appreciate it. We have a lot of good questions so far. One of the most popular ones would be, menopause and premenopause need help. What screenings and what is available for help in this area for women?
Well, this is a great question because we all go through it at some point. We're all going to have to deal with it, or we have dealt with it. So the screenings really are just about you and your care team provider having a conversation about what's going on with you. How have your menstrual periods changed? How do you feel? What's different? What are you not liking? And then we use shared decision making to try to decide, do we need any testing to understand what's going on, or does this sound like a normal menopause or perimenopausal process? Oftentimes we don't need any testing. Occasionally we will want to do some blood work like a thyroid or some other things. Occasionally we will want to maybe look for fibroids to see if there's something else contributing to super heavy menstrual periods or those kinds of things. But it's about just writing down your questions and reaching out to your provider online, in the office, through the nurse protocols, and asking the questions, and then we can start working through the answers together.
Wonderful, thank you. Next question, how can we bring up to our providers that we are stressed with anxiety and worried that it might be getting worse and turning into depression?
I think just like you did it just there. I mean, that's just perfect. You've articulated this question beautifully in a way that allows me to ask the next set of questions or to administer the PHQ-9 or GAD. If it's hard to bring it up face to face, it's okay to tell it to the person you're talking to on the phone when you make the appointment. It's completely appropriate to put it in the online messaging that most of our healthcare facilities have now and ask the question that way. You can also self-administer the tools that I talked about, and then just share that number, and that's going to get people's attention too. I hope that answers the question. If there's more detail you want there, submit another question and I'll get at it.
Right. How long is it safe to be on hormone replacement therapy, estradiol and progesterone?
This is such a great question, and it's clear that this person is an active participant in their own health. So throughout my lifetime, we've kind of swung the pendulum back and forth both ways on hormone replacement. At this point, the way I practice, based on the evidence that I'm aware of, is that we have shared decision making about what's bothering a woman about menopause, what they're worried about, what their risks are for chronic diseases that estrogen and progesterone can sometimes prevent. And then we do shared decision making together. So for instance, if one patient has a super high risk of osteoporosis and is having uncontrollable hot flashes that are making her life miserable, we're going to probably choose to use some estrogen for the first 5 years after menopause with her, as long as she doesn't have other risks that estrogen could contribute to, like some kinds of familial breast cancers. Again, it's all about shared decision making. We typically, at this point, based on what we know, we don't recommend that women that have cleared menopause and are potentially age 60 go on hormones. That would be very unusual. But right as they're going through menopause, it's very safe for women to stay on hormones for about that 5-year window. Some less, some more. It's an individualized decision. More and more, we're having women choose to have IUDs as they manage perimenopause and menopause. Most of the IUDs do have progesterone in them. I don't have any information to say that progesterone use is unsafe in that delivery mechanism long term. And so that's one that I think women could feel really very comfortable with.
Thank you. What about genetic high cholesterol? That's a factor, right?
It's a huge factor. And so your care team providers should be asking you questions like, did anyone in your family have a heart attack in their 40s or die suddenly unexplained? If we do a cholesterol profile on you and we find out that that your levels are at a sort of this threshold level for indicating genetic predisposition, we're going to probably cascade that into a lot of more sophisticated tests to understand whether you do or do not have something called familial hypercholesterolemia, because we treat that differently than plain old high cholesterol.
All right, can you talk about, oh, my little screen jumped. Hold please. Can you talk about cervical tests? Do you mean pap smears?
Yes, cervical cancer screenings would include a pap smear for cytology, where we look at the cells. And then we also now screen, when we do the pap test, for the presence of the HPV virus, because we know certain strains of the HPV virus are associated with cervical cancer development. So we follow women more closely when they have that HPV present. We used to do pap smears every year when I was a younger woman. Now, if women have had no abnormal pap smears or they've had subsequent normal pap smears, women over the age of 30 only need them every 5 years if they're done with an HPV test. So we've really come a long way in terms of understanding cervical cancer and preventing death from cervical cancer. Also, the HPV virus is, the HPV vaccine is, I think, going to eliminate cervical cancer if enough people get it.
Belly fat since menopause, how to get rid of it?
Oh gosh, I'm with you, sister. I don't know, but if you figure it out, will you please message me? It just happens when our hormones change. The fat tends to distribute into our midsection. Keeping a healthy weight and doing our core strengthening is good for us for a lot of other reasons, and so I would absolutely recommend that.
I was listening intently to that answer too. So, Dr. Horn, what does shopping from the exterior of the grocery store mean?
Thanks for asking that. So if you think about the way grocery stores are set up, we have the produce aisle, and then there's the homemade bakery part. We want to skip the sweets, but you know, the homemade whole grain breads, and then we go to the seafood counter, the meat counter, the dairy. We've got some juices and milk back there. Usually there's a whole food section and a bulk food section on the back end. Those are the kinds of foods we want to be filling our pantries and our kitchens and our children and ourselves with. We want to stay away from processed packaged foods, fake foods, as much as we can.
Wonderful. I'm 60 and suspect I have undiagnosed ADHD. Should I be screened for this?
Well, that's a great question to ask, and I would say you should talk to someone on your healthcare team about it. There definitely are adult screenings. But there could be other things that are causing your inattention that we'd want to look into as well.
How do you know if your hormones are out of whack? Like, I have anxiety and depression, but I think my hormones are negatively affecting my emotional sexual desire for my husband.
Yeah, that is such a good and hard question, because it's a bit of a chicken and an egg question as well. When we don't feel good, because we're depressed or anxious, it also does affect our libido and our hormones. Vice versa, if our hormones are off, it can make us have those things. So it's just important to start the conversation. We always ask things about, what is your menstrual pattern? What is your menstrual history? If you're cycling regularly, it's very unlikely that your female hormones are contributing to what you're feeling or experiencing. But if your cycles are off, or if you have signs of low thyroid or high thyroid when we talk about it, then we'd want to get after that, because those are treatable causes.
If we already have some of these diseases, would it be beneficial to see someone at the Women's Health Clinic, and do we need a referral?
You can start even just with your local nurse practitioner or provider to have the conversation. There are specific women's health clinics that are amazing and outstanding. And when I have women who have really detailed questions about like hormone levels and certain kinds of risks for taking hormones or desires to take certain kinds of hormones, I definitely send them to the Women's Health Clinic down at downtown Mayo. But most of my patients don't need that. Most of my patients can be helped right there in the clinic on my care team. A public health nurse could help with a lot of these questions. It's just a matter of reaching out.
At what age would you recommend a colonoscopy?
So it is recommended with lower average risk that we start doing colonoscopies or colon cancer screening at age 50. More recently, we've pulled that down to age 40. Certainly with risk, we want to start at age 40. And risk would include family history, prior history of polyps, histories of certain chronic diseases like Crohn's colitis.
At what age do you need to stop using an IUD?
You know, I don't know that there is an age that you need to stop, because as I said, it's very safe. But for the majority of women, menopause average age is age 50. Women who are using IUD for contraception, if they're 5 years post what we think their menopause was, we can usually we can almost always pull an IUD and know that they're not going to get pregnant. And they shouldn't have bleeding. If they have bleeding after that, then we have to think about, could there be an endometrial problem going on?
Dr. Horn, are you seeing long-term side effects of using anti-anxiety depression medication in women? Any reason to stop using them? Many seem like they were developed in the last 20 years. So wondering if we're seeing long-term effects.
That's a great question. And it's so funny because 2 of my patients asked me this exact same question this week. The answer from my personal experience is no. I haven't done an exhaustive literature search on this, but I'm not aware of data that shows there are long-term negative effects. It's much more harmful to a person's health to suffer with untreated anxiety and depression than it is to stay on these medications, based on what I know. That said, if you've been in a stable remission for a long period of time, I think it's okay to test the waters again under the care of your care team. Try titrating down and see how it goes.
All right, lots of great questions. And I think since it's 12:30, I think we'll transition over to Dr. Gazelka's. So for those of you who haven't had your questions answered yet, we are going to try to collate them at the end of the meeting and try to follow up and send out the answers to the questions after the fact. Attendees will also be able to get a copy of the slides that we've presented today, which have some great links included in them as well. So Dr. Horn, thank you so much. That was really helpful and very informative. I appreciate that. And so let me introduce Dr. Helena Gazelka. Dr. Gazelka serves as the Medical Director for Public Affairs across the Mayo enterprise. She attended medical school at the University of Minnesota and then completed an anesthesiology residency, in addition to both pain and palliative medicine fellowships at the Mayo Clinic in Rochester. She practices medical and interventional pain management, as well as palliative medicine. Dr. Gazelka teaches in the medical school and serves on multiple committees with national pain organizations, including the American Academy of Pain Medicine. She is a board member and has chaired the opioid committee. Dr. Gazelka has a passion for understanding the opioid epidemic, finding solutions, and educating both the medical community and the lay public about it. So it is now my pleasure to turn the presentation over to Dr. Gazelka.
Thank you so much, Beth. Let me first echo what Jen and Beth said. Thank you for being here today. Thanks for taking an hour out of your day to think about you and take care of you. It's an investment for all those that you love. I have many colleagues who would say, why in the world would you get on and tell your personal story to people who could be patients at Mayo Clinic? I am just like you. I'm a mom, I'm a wife, I'm a sister, I'm a Grammy, I'm a friend, and I'm a physician. So we all have something in common, and I hope that you'll get something out of my story today. You know, I have always wanted to be a physician for as long as I can remember. Well, before that, I wanted to be a teacher, but that was only because I didn't know that women could be physicians. Anyway, it's always been very important to me to treat people, and particularly my patients, as I would want to be treated. As Beth said, I'm an anesthesiologist and with advanced training in both pain medicine and palliative medicine. And so many of my patients are fearful, scared, and intimidated by the Mayo Clinic and their diagnoses. The purpose of my job, as I see it, is first to make them understand that I want to know about them as a person before I take care of them as a patient. Then I also want to bring them comfort as I provide them excellent medical care. This past April, I learned what it is to be a patient. Now, something you should know about me, I've always followed the rules. In high school, I was the nerd who didn't drink or smoke pot. I was worried about my brain. I knew I wanted to go to medical school and I didn't want to mess it up. I've worked out regularly and eaten well since the age of 15 at least. I've always been convinced that I should not ask my patients to do what I would not do myself, to maintain their weight, to get their preventative health screens, to live a healthy lifestyle. So when my internist told me to do certain things for preventative care, I did them. I sent my stool to the lab for Cologuard. Now, I admit it took me 3 months to collect the stool sample. I was so grossed out by having to do that, but I did it. And I had pap smears right on schedule. And then starting at age 40, I had the mammograms every year. I went back for repeat images if I was called to do so. And once I even had a biopsy of benign tissue. I even enrolled in the Mayo magnetic breast imaging study some years ago that was for women who had very dense breasts. So I had just had a mammogram in February of this year before all of this started for me. They called me back for more images again and told me all was fine. Then when I was in the shower in March, I found a very, very, very tiny firm nodule in the left upper outer quadrant of my breast. I literally thought nothing of it. I had stopped doing self-breast exams years ago. I have no risks of breast cancer, and my breasts are too lumpy anyway, so what good does it do me? This time, I just happened to be washing my armpit in the shower and found it. Like a good doctor, I ignored it to see if it would go away. Forgot about it, really. A couple of weeks later, I was scratching an itch while watching TV, and I felt it again through my t-shirt this time. I was sitting next to my husband, who's also a Mayo Clinic physician, and I asked him what he thought. He said, why don't you just go get that checked out? At least get them to tell you what to do about all of those lumps and bumps that you get, so you don't have to worry about them all. Well, I didn't really worry about them all, to be frank, but I got tired of asking. I didn't rush right out, I can tell you. I thought about how it would be bothering my primary care doctor. I definitely didn't want to seem paranoid or needy or that I was jumping on something that wasn't important, I thought. So finally, I went to the breast clinic at his recommendation. And the day of my evaluation, the provider didn't know I was in the room. So I sat there and waited, and the provider was about 45 minutes late because they hadn't turned those little lights on by the door. I was about to leave, in fact. I tried to go, right? I did my part. And I definitely didn't want to go up to the desk with my Mayo name tag on and seem demanding and ask where the provider was who was supposed to see me. But in the meantime, while I was waiting in the room, I read all of those posters that they have on the wall about things that I do right. Nope, I'm not overweight, so that's okay. Yep, I exercise, so I'm good there. Nope, I don't smoke. No, I don't have a family history of breast cancer, and I had my first pregnancy at age 20. You've got this, Helena. So when the provider said, we need to biopsy this, I was surprised, but not alarmed. In fact, I sat alone and read my own pathology report in my office the next day. Invasive breast cancer. Invasive breast cancer? What? How? This is not my life. This has to be some kind of a mistake. And so what was not my life very much became my life. With care from incredibly gracious colleagues, I embarked on life as a patient. Another biopsy attempt, lab studies, consultations with surgery, with oncology, with radiation oncology, waiting and waiting and waiting for results. How big is it? Are the tumor markers okay? Are the margins negative? And more waiting. In waiting rooms, I found this the hardest. I did not want to be a cancer patient in the oncology waiting room, or the radiation oncology waiting room, or the genetics clinic, or at the pharmacy. And if one more person asked me those 4 questions about my fall risk while I was checking in for an appointment, cheerfully, I put one foot in front of the other, smiled and thanked everyone. Many coworkers recognized me. I make a podcast weekly for Mayo Clinic. Oh, you're the Q&A lady, right? So then off to the operating room finally for a lumpectomy. That was one of the hardest things because I'm an anesthesiologist. It was a little awkward for me to ride by in the hall and to be naked in the OR in front of my colleagues. Then I took just 5 days off from work. I wasn't really off. I was in Zoom meetings from 3 days post-op on. But was it all as easy for me as I tried to make it seem for others? I was anxious, waiting for hours in the proton beam waiting room, feeling that sense of loss of control that most of us have felt in the past year at some time or another during COVID as well. It seemed the best way through was just to hurry up and get it all done with. By that, I mean surgery, radiation, etc., doing the things that I was told to do. But I had this nagging sense that this just is not fair. I did it all right. I did what I was supposed to do. I am healthy and I keep a schedule and I spend my life caring for others. Both of my parents died of strokes related to dementia in their mid-70s. Is that still going to happen to me too? That was my biggest fear prior to having breast cancer. Meanwhile, gracious colleagues, coworkers, and friends dropped off gifts and sent cards and emails. I told them all that I didn't really need to have meals cooked. That's what husbands are for, right? My husband loves to cook. So please, if you think about me, send a note instead. And boy, did they send notes, hundreds of them. It was like bathing in love daily. I realized I had not been a very good friend to others when they were going through tough times. Sometimes it's just so difficult to know what to say, isn't it? I had to recognize my own lack of control. And it is, I realize, a good thing that I'm not in control. I did not ask for cancer. I did not welcome it. I banned it from my body as quickly as I could. But I did feel a little threatened by it. It was, if it could be lurking there and arise unknown to me, what else could be lurking? But I have a very strong faith and a sense of purpose that helped to carry me through. I realized that my way of coping actually works pretty well for me because I keep a very structured life, up every morning at 4 a.m. to work out, working hard for Mayo Clinic and our patients and enjoying life too. That made this cancer chapter tolerable, if not meaningful. I've had a practice of gratitude for many years. Dr. Amit Sood wrote a book about stress management and resilience, and one of his recommendations in that book is to practice gratefulness. I have taken that with me every single day since I read that book and heard him give a talk about it. In the morning, in the car on the way to work, I list at least 5 things or people that I'm grateful for and why I'm grateful for them. I try not to repeat the same things in people every single day, but I admit that my grandsons, Liam and Owen, get to show up on the list every day. They're the only ones, probably. Today, I am grateful that I am cancer-free. I will take tamoxifen for 5 years, and I will faithfully present to the breast clinic to be followed. And I will keep up with the preventative care calendar prescribed by my own physician. The thing is, even if you do it right, according to the rules, things can still happen, like cancer. We're not in control of everything in our lives, as much as we like to think we are. So know yourself. Be consistent with what you think works or matters, because it might, like self-breast exams for me, I felt those were pretty worthless, but now I'm back to doing them, I can tell you. And if you think something isn't right, then bother your provider. That's what they're there for, right? Also, if you know someone who is ill, or has a family member who is ill, or is going through a divorce, or has kids who are misbehaving, or has anxiety and stress due to COVID, or anything else, reach out. Send that text, card, or email to let her know you care. That really made the difference for me. After all, maybe we are all put here on earth to make life just a little bit better for someone else. Maybe a little more meaningful, a little more bearable. As I say at the end of every Q&A podcast, I hope that you learned something. I know that I did. I have grown and I continue to grow through my own experience as a patient. I hope that these experiences make me a better doctor, friend, and human being. I will not spend my life worrying about cancer returning. My mother did not have time to tell me many things that I wish I had remembered to ask her, but she had one message that she repeated over and over throughout my life. She would see how impatient I am, and she would say, "Don't wish your life away, Helena. The next big thing, goal, task, accomplishment will come soon enough. Learn to live in and enjoy today." And that's just what I'm going to do. To live my life with joy, to live it in the best way that I know how, to live it to make each day just a little bit better for every patient that I see. Thank you for being here today, and thank you for listening.
Thank you so much, Dr. Gazelka, for sharing your story. That's really impactful. And I think that's a great reminder too, sometimes to reach out to those friends who might be going through a tough time. I know it's easy to get, everyone else is busy.
Oh, someone else will do it, not me.
Yeah. Exactly. So thank you for those amazing reminders. I appreciate that. One of the attendees said, "It's not a question, just a comment, but nerds are awesome people." So noted and agreed.
It usually works out okay in adulthood.
Right, exactly. Oh, one thing, I think you had mentioned a book, and how do we get screened if we are uninsured? Do you have the name of the book?
Oh, the book is, I'm trying to remember it now, just when I was saying that during this talk. The physician's name is Sood, S-O-O-D, and his first name is Amit, A-M-I-T. And I think it's SMART, Stress Management and Resilience, something along those lines. I can find it though, and we can answer with that.
And I believe getting screened if you're uninsured, I believe there is a way that you can request a screening mammogram through other programs. I don't know them off the top of my head, but maybe we can send some of that information after.
I think that's true. And I admit that I bet that Jen Horn knows more about that than I do. She's a primary care provider.
That's very true. Dr. Horn, do you happen to know that offhand?
Most healthcare plans will include screenings. If you are uninsured, then I would have to connect in with community resources, but I know that there are opportunities. I just don't have it on the top of my head. And I might ask Jeff to turn my video back
on. I think
I saved time for questions for Dr. Horn.
Yeah, maybe we can pivot we can keep answering some of the questions that were submitted. These are great. Kelly mentioned the book is SMART with Dr. Sood, I think.
Oh, thank you very much for that, Kelly.
Thank you. And a great comment about this was amazing. So, Let's see. Let's go. All right. I've been on estrogen replacement for more than 20 years. I tried over-the-counter methods about 2 years ago and had extremely bad hot flashes and could not sleep over 7 months. So I asked to be put back on the estrogen replacement. I'm 75 years old. Any studies on how much longer I will have hot flashes? I had a total hysterectomy in 1986 due to widespread endometriosis.
This is a really hard question. And not an uncommon one. So as long as people are taking estrogen, they're always going to have hot flashes when they go off of it. And so it's a matter of, you know, when is a person ready to bite the bullet and try it again? The older we get, the less our estrogen stores in our cells are there. And so it should get easier as a person gets older. But every woman is different. I know my next door neighbor had the exact same scenario as you, questioner, and finally she just got really worried that it was going to cause a blood clot or something in her, and she decided she was just going to bite the bullet. And it took 6 months, but she got through it. So again, I would say talk to your team. This might be a situation where you want to go to a women's health specialist and get some other hormones measured, and talk about what is your actual risk of staying on it versus going off. Because obviously, if your life is miserable and you can't sleep, you know, it might be a risk that you're going to continue to take.
Thank you. Dr. Horn, what do you recommend for those who do not have a family history? What questions should be asked? What tests do I do as a 32-year-old female? I'm adopted and have no ability to get my biological tests as I am from a third world country.
Great question. You would do all of the tests and recommendations that I talked about. And then based on sort of what we find from that and what we find from your physical exam, we might try to do more. But you would for sure want just all the baselines. If you know your genetic heritage, there might be some diseases that we would want to target. If you get genetic testing done, that helps you know your genetic heritage. That could help us as well.
Thank you. Similar to a previous question, but with a little different twist. Is there anything that we can do or you would recommend for helping your sex drive at all? I've been told that it's because I'm not currently trying to get pregnant and it is mental. Well,
I'm sorry that sounds like a kind of curt answer. And obviously there's a lot of complexity to our desire for intimacy. The 3 things that I talked about in terms of adopting a healthy lifestyle, they all help with our overall sense of well-being and our libido. So exercise, healthy eating, getting as close to a healthy weight as we possibly can. Accessing intimacy is usually a first step back into having more libido for sexual activity. And so just simple touch type things, talking to your partner about it. Those are the things I would recommend.
Thank you. One of the attendees said, highly recommend the Mirena IUD for menopausal symptom management. It's like, what's menopause? My Mayo NP guided me to this option. Haven't had one regret. So.
IUDs are a game changer for women of all ages. Long-acting reversible contraception and an amazing way to manage menopause.
One of our attendees said many breast cancers seem to be in that upper outer quadrant. Is there any validity to the possibility that aluminum and deodorant can cause breast cancer?
I'm not an expert on this, and so I will have to defer. The upper outer quadrant has by far the most breast tissue in it, and so I know that that's a factor in terms of why they're there.
Thank you. One of the attendees put in the low-cost screenings website into the Q&A if those of you who are able to access it. So thank you so much for including that. It's a cdc.gov website. So I'll leave it in the Q&A for those of you who want to take a peek at that and click on the link. So thank you to the attendee who shared that. Another attendee said, I'm 58 years old and I cannot sleep. I'm lucky to get 4 hours of sleep. What can I take over the counter or that is safe to take? I've tried so many things.
Oh goodness. So the safest things are going to, over-the-counter things are going to be products like melatonin or teas that have things like valerian in them. You'd want to make sure that you feel they're safe for you. Valerian shouldn't be taken if you're pregnant, for instance. Antihistamines like Benadryl are very effective, but a lot of people don't feel good the next day. They're not addictive, they're not dependency forming, but they just don't feel good to take every day. Most of the prescription sleep aids are not fully safe, and so we really try to not use those. One thing that is very effective and can be a cure is behavioral therapy techniques. So you can access that online through online counseling. There are apps on your phone that can teach you behavioral techniques for managing insomnia, and that can cure insomnia. And then of course you'd want to make sure you don't have another disease like sleep apnea or something, or restless leg syndrome that's disturbing your sleep, because we need to treat that if you have it.
Wonderful. The next two questions are very similar, so I'll kind of combine them. I'm in my mid-30s or recently turned 30. What kind of screenings beyond breast cancer screenings and PEPs should I be aware of when I approach my 40s? Are there things I should look at more than I have in the past, or anything that should request to be reviewed that I haven't had before? I know our insurance pays for yearly physicals and blood work, but I've never gotten these ordered unless it was during pregnancies. Should I worry?
I would say you shouldn't worry as long as you're confident that your provider really knows your history, both your personal history and your family history. If you and your team have talked about that in detail, then they should be offering you all of the screenings that you would need. There really aren't a lot of screenings that are kind of new or different between the ages of 30 and 40. I highlighted all of them for you in the outline, and anything additional would be based on risk.
Thank you. If cervical cancer is in the family, a cousin, should I be tested? I am 67 and this isn't normally done at this age. My cousin is 62 and just diagnosed.
Well, I'm sorry for your cousin. Likely she'll do really well because we've come along so far. Interestingly, cervical cancer is really an environmental cancer, and it's an HPV related cancer. And so it is unlikely that there would be a familial thing there. If you've had all of your normal pap smears at the right intervals up to the age of 65, which is when we stop, and you've not had abnormals, and you're not a smoker, and you don't have new partners, then you don't need more screening. If you do have new partners or any of those other things, you would want to talk to your team about it.
Dr. Horn, who's at risk for bone density?
So this is another great question. So women who have small frames, who are from certain heritages, women who have a parent that have had a hip fracture, interestingly, would all be considered at risk. People with other metabolic diseases, like eating disorders or untreated thyroid conditions, those would be people that would be at risk as well. People with calcium disorders in their blood, those people would be at risk. People who have to take prednisone long term, those folks are at risk. And there's some other drugs that can put you at risk as well.
Thank you. Another good one. I have a thyroid concern that came from my cholesterol test. Should I be worried about that?
I don't understand that question fully. I would want to ask more questions about that question. So I would recommend that you ask more questions of your provider about that question.
Dr. Horn, how do you go about not getting completely judged by obesity? Symptoms can prevail even though a person is obese, correct? So how do you go above stating that you are concerned and it's not just about losing weight?
You know, I don't know that any of us feel like we're expert on this. It is so hard and it's so sensitive. And I mean, I don't know very many women who haven't had issues about their own kind of body image. You know, we try to be as sensitive as we possibly can and talk about health. This is particularly sensitive in the adolescent and childhood age groups that I take care of. We don't want people to be stigmatized, but we also need people to understand the effects on their health long term. what we do know is that for people that are overweight, if they're active, their risk is actually lower as long as they're active. Unactive skinny people have a higher risk than active overweight people. So I tell people things like that to help them feel empowered and motivated. And then we work on, what are your goals? What would you like to see different? Or how do you feel about your body? How is it affecting your life in a negative or positive way?
Dr. Horn, is HPV vaccine available for women in their 40s?
The short answer is yes. The longer answer is not usually on a protocol, but it's certainly something that you should talk to your team about. And if you're a single woman in their 40s, I think it's a great idea. I think if you haven't had the opportunity to have it and you're a single woman, you should go for it and push it, because you might get a no, but I would recommend pushing it.
All right, we probably have time for a couple more. I'm a 70-year-old woman. I and my friends are and have been active through our lives. Almost all of us have osteoporosis or osteopenia. It seems like it is inevitable to have bone loss after menopause. Any new research to prevent bone loss?
So things that you can do lifestyle-wise are to make sure you're taking your calcium at a level of 1,000 to 1,200 milligrams a day, 800 IU's minimum of vitamin D, weight-bearing exercise, which this group of active women is clearly doing. Know your genetic risk. And if you have high genetic risk, then consider going on a medication to prevent further bone loss. Those are the main things. And estrogen also prevents bone loss. So if there's other good reasons for you to take estrogen in the perimenopausal time, then that can be protective as well. But that's interesting that your whole cohort of friends has this. I don't know, as a clinician, that makes me interested in understanding you guys more.
Mm-hmm.
Smoking makes it worse. High caffeine use can make it worse. Alcohol can be associated. So it's that healthy lifestyle stuff.
All right, well, we'll end on a really nice positive note. Thank you, Dr. Gazelka, for your idea of 5 grateful things a day and your Q&As. Love them. Also, I can't believe you're a grandma.
No, right?
I know. Amazing. Oh, well, thank you so much, Dr. Horn and Dr. Gazelka. I mean, these were informative and engaging presentations. The Q&As were great. I really appreciate that. I'm sure each of us now has a list of takeaways that we should refer to after the webinar. I'd also like to thank everyone who took time out of their busy day to join this webinar. It looks like we have about almost 150 attendees. This is just wonderful. So a brief survey will be sent to you in the next few days, and we appreciate your feedback, which helps us plan future programs. So in the meantime, thank you again for joining. We appreciate it. We hope to see you next year in person. So take care. Have a great day.